The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I'm Laura Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Ms. Jennifer Hinkle, our expert presenter, for this first of our second installment of eCourses in the series hosted by the Institute for Clinical Immuno-Oncology, or also known as ICLIO, who will discuss alternative payment methods beyond fee-for-service. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapy, includes other vital resources such as newsletters, papers, a scholars program, and our national conference, which will be held September 30th in Philadelphia. Please visit www.accc-iclio.org to browse all of our offerings. Now for today's eCourse, I'm pleased to introduce Ms. Jennifer Hinkel, partner at McGivney Global Advisors. Ms. Hinkle is a current partner. She's leading engagements with major pharmaceutical and biotech companies. She's a leader in specialty pharmaceutical policy, pricing, coverage, and reimbursement. Ms. Hinkle is a recognized expert in development and execution of health economic and financial models to inform biopharma strategies. She has served as industry analytics lead for Genentech, where she led development of the company's financial assessment and forecast for the Affordable Care Act. She's also served as Business Insights Lead for the National Comprehensive Cancer Network and is former faculty in the health services at Penn State University and health economics at Arcadia University. Ms. Hinkle is an alumna of the Roche Pharmaceuticals International Global Leadership Rotation Program, and she's earned her master's in international health policy from the London School of Economics. Jennifer is also founder of the Resilience Racing, an all-cancer survivor sailboat racing team, an award-winning healthcare technology entrepreneur, and has authored several publications on healthcare management, oncology policy, and entrepreneurship. And for a few housekeeping notes, please feel free to submit questions of your presentation and by typing into the box on your dashboard, and we'll pose questions to Ms. Hinkle at the end of the presentation. The webinar will be archived and will be available on the ICLIO website shortly. Now I'll send it over to Jennifer Hinkle to kick off the webinar.
Lorna, thanks very much, and thanks for such a generous introduction. I'm really happy to be here to talk about alternative payment models and some of the policy issues going on right now that are impacting oncology and will continue to impact the practice of oncology. So we can go to the next slide, please. So for the webinar today, I have 4 general learning objectives that I'm hoping that we can get through. The first is to understand where we've come from in the context of reimbursement for physician-administered, which are Part B products, and we can talk a little bit about oral products as well. The second is to understand the basics of some of the acronyms that are changing the way that these drugs and services could be paid for. So those include VBM, MACRA, MIPS, and OCM, and we'll get into what each of those are. Third, I'd like us by the end to be able to identify some potential models of alternative payment and how these could impact cancer care delivery. And then lastly, to understand some provisions of Medicare's proposal for reforming Part B and what the potential impact to care delivery might be for practices, for patients, providers, and all of us who are stakeholders in oncology care. Next slide, please. So to put alternative payment models in context, if we go to the next slide, I have a timeline of where we've come from. And on the top half of this chart is what we've seen in the Medicare policy environment. And then underneath the timeline arrow is showing how the reimbursement context has evolved over time. So for those of us who might have been in this area prior to 2003, you might remember getting reimbursed based on AWP, average wholesale price. The Medicare Modernization Act changed that, and so we've been more than a decade now in an environment where we've had reimbursement for Part B physician-administered drugs, which are all of the infused and injectable drugs, where we've had ASP-based methodology. And we've been getting reimbursed at an ASP plus 6% since about 2003, so for a little more than a decade, although there have been some changes that have occurred that are kind of chipping away at this ASP plus 6% Medicare reimbursement. So back in 2011, the Budget Control Act introduced the concept of sequestration. So that occurred because Congress wasn't able to come to agreement on a budget and the debt ceiling. So you might know that there were some automatic cuts that were made across the board, not only to Medicare, but to many other government-funded areas in the U.S. That order was signed in March of 2013. And what we now are living in is an environment where we have a Part B reimbursement rate of approximately ASP plus 4.3%. So that was a 2% cut to both the ASP base and the add-on payment that took us down to about a 4.3% add-on. And as we're looking forward, really starting, I guess, last year in 2015 with the proposal and initiation of OCM, the Oncology Care Model, and now the Part B reform proposal that's been circulating for a little more than a month, we're seeing CMS really want to move away from fee-for-service and more towards an idea of paying for value and paying for outcomes. This is really complicated to do, and we'll talk about some of the models they're proposing that would try to do this and why it's so hard to change the status quo here, but also why it's very risky for many practices or providers if the status quo changes and this ASP-based reimbursement were to get chipped away any further. And then I do have another arrow on the chart just to show that in the midst of all of these changes going on with Medicare, or proposed changes going on with Medicare, many of you have probably already seen or engaged with pilot projects or demos on the private payer side that are looking at the same idea of moving away from a strictly fee-for-service-based reimbursement and the payers trying to reimburse a little bit more for what they see as value or what they see as outcome. And for those who have participated in some of those projects, again, you'll know how tricky this is, especially when we get into the definition of value and outcome and what we're measuring and what data have to be collected to do this. So let's go to the next slide. And so if we think about CMS and what I would call over a decade of changes in Part B, one interesting thing from a policy standpoint is that in 2003 and through sequestration more recently, physician groups and stakeholders have clamored to say to CMS, the sky's falling, this change in reimbursement will mean that we can't treat patients anymore. And I think what's happened, which maybe has lessened the potential impact in turning back this tide, is that CMS says, okay, really, is that going to happen? And then after the change gets into place, there isn't a hugely measurable impact in a negative way to CMS, and the impacts to patients maybe aren't immediately visible. I don't think that means that there isn't a really significant impact, and I think there's probably data out there to support what practices and providers have had to do after sequestration in particular in terms of laying off staff or tightening up efficiencies, maybe not changing the way that they prescribe, but referring patients who aren't as well reimbursed out to other institutions because maybe they can't afford to practice in the same way anymore. So I think from a policy standpoint and an advocacy standpoint, if we're thinking about how to leverage the voice of community oncology to support that community and argue against these changes, that's an important perspective to consider. Secondly, many people in Congress still think that a percentage-based add-on is incentivizing the overprescription or the selection of more expensive drugs over less expensive ones. You know, clinically that probably is not happening except maybe at the fringes, but this is a perception that's really widely held among lawmakers, that there's this perverse incentive to choose a more expensive drug even if a cheaper one existed. And so I think that that's always something that has to be argued against or pushed back on anytime there's discussion of changing Part B. And then the third interesting point is that there are issues around 340B reimbursement, 340B definition of a patient, and a lot of questions about the future of that program. But this Part B new proposal doesn't address 340B at all. 340B institutions still would have the largest margin under any of these proposals that that we're going to talk about. So the reimbursement is not necessarily carving that out, which is something interesting to note. Next slide, please. So when we're looking at approaches that CMS or private payers could take to change reimbursement and pay according to an alternative model, there are really three levers that they have. The first lever is the add-on payment to ASP. The second lever is an administration fee. And then the third is to truly incentivize value or outcome. And the reason that the incentivizing value or outcome is in a different color is because this has been really hard to do based on the data that CMS and private payers are collecting right now. So even though it's really an admirable goal, and I think everybody would like to see a world where the better value you provide or the better outcome you provide is then rewarded, it's very hard to track and measure those. Another point is that none of these methodologies account for the total cost of care. So you can squeeze people on the add-on payment, or you can lower the administration fee. Sure, that's going to bring costs down. But if you lower those and then you drive people away from using the drugs that they maybe should be using, or you disincentivize that, you could actually lead to an increase in overall spending. So for those of you who might be familiar with the pilot project around chemotherapy bundles that United Health did, the lessons coming out of that are really that you can spend more on drugs and then reduce your total cost of care, because if you're spending more appropriately on drugs and using them more appropriately, you can reduce hospitalizations and other things that are very, very expensive incidents that can be avoided by use of pharma and biotech products. Next slide, please. So where we find ourselves now, hospital outpatient departments and physician practices and clinics are getting reimbursed by this ASP plus 6% that's been reduced to an effective ASP plus 4.3%. At the same time, we're kind of in this alphabet soup of Medicare proposals and programs, many of them still at the demo level. And at least in our office, we have a little bit of a joke that the oncologists are suffering from a diagnosis of widely disseminated pilot projectitis on the commercial payer side. So it seems like everybody's got a pilot project and a demo. On the private payer side, Medicare has the oncology care model and now this new proposal. It's going to be really complicated to kind of sort out who's doing what reimbursement schedule you're on if these all come to pass, and then what the actual impacts are and the results are in terms of financial outcomes, but also potentially clinical outcomes. So let's get into that next section of talking about what some of these are. And I don't know, it might just be my internet connection, but I'm seeing, okay, here's the next slide. I'm sorry if there's a little bit of a delay, but the slides are coming up a little slowly for me. So looking at some of this alphabet soup, VBM, OCM, MIPS, and MACRA, let's get to the next slide and talk about what each of these are. So the value-based modifier, VBM or VM, this is actually one that's been around for about a year now, and this is an adjustment to physicians based on certain cost and outcomes measures. So the value-based modifier is looking at retrospective data, so changing your 2016 reimbursement, for example, based on 2014 data of where your practice falls in spend. But these are pretty small adjustments, just by a percentage point up or down, and at first they're only applying to really larger practices, and then that will be rolled out further and further as time goes on. The second one to think about is oncology care model. Some of you might be participating. The oncology care model is a Medicare demo that's creating additional incentives for meeting episode-based outcome measures. An important thing to note that we might talk about a little bit more is that the oncology care model does not fundamentally disrupt getting paid on an ASP basis. So you're still getting that ASP plus reimbursement, but you're getting additional reimbursement for meeting certain measures. Third is MACRA. So MACRA is a piece of legislation, the Medicare Access and CHIP Reauthorization Act of 2015, that's creating a framework for these alternative payment models and what CMS refers to as MIPS. MIPS is Merit-Based Incentive Payment System. And so what MIPS does is combines aspects of the BBM, aspects of electronic health record incentives that have been going on for meaningful use, and PQRS, the Physician Quality Reporting System, into a single incentive program. And CMS is hoping that what this will do is just help facilitate the rollout of alternative payment models with these metrics attached. And there's a link at the bottom there. If you go to the CMS website, it's a lot to type in, but if you type in CMS macro MIPS APM, you should be able to find that page pretty easily and read more about it. Next slide, please. So one question, are all of these, the value-based model, for example, or the oncology care model, considered alternative payment models? Well, they're slightly alternative to maybe what's going on now, but they're really just tweaking by adding incentives or disincentives to the existing payment program. So neither of these are wildly altering the fundamental of getting paid based on ASP. But if you look at what macro might be opening the door for, or you look at what the changes are floated in the latest Part B reform proposal, there are definitely some potentials there to be moving away from the ASP plus a percentage model that we've all gotten used to. If we look at the Part B proposal, especially in what they call Phase 2 and getting into an idea of value-based pricing, indication-based pricing, or purchasing and reimbursement, those are really some major areas where we would start to see the model move away from ASP into these different forms. So we'll talk a little bit about what forms they can take and some of the big buckets theoretically underpinning what these alternative payment models are. Let's go ahead. So we'll get into a couple of the potential models for alternative payment. So here I have a chart that shows on the left going from a fee-for-service buy-and-bill environment, which is our current model, down to what could be the most potential change, and we'll go through each of these, as well as on the right side, there's an example. If we see any kind of current or past pilot or model in action, just to ground all of you into what that might look like. So fee-for-service buy-and-bill, that's what we currently have. Buy-and-bill with an incentive for products on pathway. We see a model that Anthem is floating where you get a bonus payment if you stick on a pathway. And then similar to this, another flavor in this kind of category I could call B&B plus, buy-and-bill plus, are shared savings and value-based elements. So we see the value-based modifier or the oncology care model. Again, you're still getting that ASP plus, but you get a little bit of an incentive if you do other things or meet other measures that are established. The next one, a flat rate buy-and-bill. This is a little bit what the Part B reform proposal is moving towards. So not specifically because it's not giving you just ASP. The proposal is you get ASP plus a much smaller percentage and then plus a flat add-on. But what this would do is try to move away from that ASP-based incentive where for a more expensive drug you actually get more margin and move over to other payment types. Similarly, the idea of a third-party buy-and-bill, this is similar to when CMS had the competitive acquisition program, which at least in oncology was kind of a flop, where you would just pass through all of your drug costs that would get delivered by a specialty pharmacy or maybe some other sort of specialty distributor, and you might get an administration fee. This didn't really work out in oncology, although there were some other specialties that participated a little bit more fully or with more interest. But these are two kind of models that, all right, it's still a little bit of a buy-and-bill because somebody's buying and billing for the product, but not with any additional margin on it. Moving farther away from that and getting rid of the buy-and-bill concept completely, we move into the idea of episodic or bundled payment, capitated payment, global budgets. So we could have some kind of episode or bundled payment that just focuses on the drugs used. So that could be similar to the demo that United did, or we could have an episodic or bundled payment where the total cost of care or a global budget is used to manage a certain diagnosis or even manage a patient population. So if you look outside of the U.S., there are some models like that. If you look in the UK at the NHS, there are many physicians or geographic areas that hold a certain budget that then have to provide care for all of the people within that catchment area or within that category. Let's go to the next slide. So there are three primary models if we use that chart to think about reimbursement reform. So the first would be that buy and bill is fundamentally maintained, but there are some adjustments up and down. This would likely be the least disruptive model, although it could end up being quite a squeeze financially if there are downward adjustments. So that's something to think about. The second is that buy and bill is shifted so that the margin or incentive is moved away from the provider. So if we have that third-party distributor, similar to that CAP program, the physician is not necessarily, or the provider is not necessarily holding the risk there. But the hard part about applying that model in oncology is that there are all of these services around pharmacy and administration that aren't really fully or separately reimbursed that might have to be made up elsewhere if that drug margin were to be taken away or moved to a different stakeholder. And then the third, which would be the most disruptive in my mind, alternative model of payment would be for buy and bill to go away completely and to have some kind of episode or bundled basis of payment with outcomes or value as a fundamental. Actually, if we could move smoothly to a model like that, it might not look that bad in terms of financial impact. It might actually be the same kind of kept whole scenario, but it's really hard to move to that because, again, we don't necessarily have the technological capability to measure and track and pay according to outcomes, and there's a lot of disagreement over what value really means. Let's go to the next slide. So the current Part B reform proposal, we'll just go through a few of the elements and implications of this. And then I know that there are also many questions from the audience, so we'll take a couple of questions as well. So the proposed Part B changes are really in two phases. The first would be a change to the add-on, so no more ASP plus 6%, which is now effectively ASP plus 4.3%, but the much lower add-on of an ASP plus 2.5% plus a flat fee of $16.80, which in oncology, where we're dealing with some pretty expensive agents, is really a very big cut to reimbursement. Phase 2, CMS is talking about adding in some value-based purchasing tools. I think it's kind of surprising that they have referenced ICER as perhaps one potential arbiter or source of information on what might be the approach to value-based purchasing or pricing or indication-based pricing. And I'll get into that a little bit. So again, this would lead to a drastic reduction of reimbursement with products where the ASP is above a certain threshold. And CMS has acknowledged this, that it would kind of be a shift away from right now these specialties that are using the more expensive drugs and a shift of funding into primary care, which is maybe a little bit alarming just because of the amount of these Part B drugs that do flow through these specialty practices and how integral a part of the clinical practice of those oncologists and other specialty providers that the Part B drugs are. There would be mandatory participation with regional or geographic randomization by primary care service area of who would and would not be participating in the new model. So this would mean that some areas would be told that they have the reimbursement as it is now, and some would be told that they are subject to the new model and it would be mandatory. CMS has acknowledged that this overlaps with the oncology care model. OCM practices would not be exempt, but they would also be randomized to be in the higher or the lower reimbursement. So I could see that being quite a headache for those groups who have really tried to get their heads around OCM and prepare for it, and now this new thing is coming down the pike and might shake up all of those preparations. Definitely something to be concerned about. Phase 2, with the specific mention of ICER, I think should be a significant red flag for providers, for patients, and for biopharma manufacturers, just because, well, because of a lot of reasons, but one key one is that ICER relies on the quality adjusted life year as a metric. This metric has been demonstrated to be discriminatory and lead to poor outcomes and lower cancer survival rates in countries that use it to determine reimbursement. So an example there is the UK. These kind of methods for cost effectiveness that ICER uses have come under a lot of criticism. I think ICER is coming under quite a bit of criticism due to not only their approaches, but their stakeholders who are involved in creating these reports, their lack of inclusion of patients and practicing physicians in specialty areas on some of their reports and publications, and then what their funding sources are. So I think ICER is something for everybody to pay a little bit more attention to and dig into a little further. Phase 2 also very interestingly suggests that CMS and manufacturers might create some kind of risk-sharing agreements based on outcomes. There are some risk-sharing models that we see for market access of new pharmaceuticals in other countries. It's not something that we've seen much of in the U.S., although it's something that there's quite a bit of buzz around. So that will be something to watch as well. But just a heads up that these risk-sharing agreements also require a lot of tracking, a lot of measurement, and they also require everyone to come to an agreement on what the target outcome is for any particular agreement. So they're not necessarily easy to create and administer. Next slide, please. All right, so let's move on to some questions. So I think, Lorna, you have some questions coming in and can ask them.
Yes. Again, thank you, Jennifer, for a wonderful presentation. And we received a lot of questions from the audience, so obviously a very timely and relevant topic. So one of the questions we received, so it seems like with the randomization into different models, there are different financial risks for different arms. Any ideas of how practices will be made whole, or if they will be made whole?
So that's a really good question. So I'll just say, for those of you on the call who might not know what's meant by being made whole, it means will the overall reimbursement or overall income level coming into the practice be maintained the same? And I don't think that that's really seen as a super big priority for CMS when they're developing these demos. So I would say, unfortunately, I do not think there is a provision to necessarily keep everyone whole using this model. I think the idea is that by making a drastic change, they would actually change behavior, and maybe not only change behavior of providers and practices and hospitals, but potentially change behavior of manufacturers in pricing.
Great. Thank you, Jennifer. And how would CMS determine who would get lower reimbursement and who gets higher reimbursement?
So for this model with the Part B demo that's being proposed, what would happen is that geographic areas would be randomized to fall into different categories of reimbursement. So it will be a random selection. It won't be kind of two practices that are located right next to each other, most likely. It will be by primary care service area. So you can look online and get an idea of how big those are and where the geographic lines are. But there is quite a bit of discussion in the proposal by CMS about how to select an appropriate geographic area, because they acknowledge that there are many big practices out there that might span across entire states or across multiple states. What does that mean if some parts of a practice are in one reimbursement model and some are in another? I think that this actually is a part that CMS has put a good amount of thought into. That doesn't mean that it's perfect or that it's favorable. So, if you're really curious about that, I would say definitely look at the proposed rule, and also look into what primary care service area you're in and how large that area is.
Okay, thank you. And Jennifer, do you know where the $16.80 came from?
I do not know where that came from exactly, although I have some speculation and suspicions, although I don't know that I should just wildly speculate on a call. I mean, I think one possibility is that CMS picked a number and they said, okay, so with a drug of this ASP, theoretically, let's make anything below that stay whole, below that ASP, have the 2.5% plus 1680 stay whole, or actually get an added incentive through this model, and then let's have any drug above that price kind of not stay whole. I think that might have been one way that they backed into it, but I don't know that it's really specific. It might just be a stake in the ground number to argue on. I would say, very interestingly, when I've worked with biopharma manufacturers in the past to model out some of these potential payment models and to see what the impact would be to practices, we always assumed that any flat add-on would be much, much higher than that. So flat add-ons more in the area of $100 or $250 or $500. So I think that this number is pretty shockingly low for a lot of us looking at it, and I think that would be a really good question to ask through public comment of where that came from and how they're justifying it.
Okay. And let's see, another question coming in. Does CMS have an official definition of quality or value?
I do not think CMS has an official definition of quality or value. I think that there are definitions out there people talk about from Institute of Medicine or from other groups. CMS really hasn't been in the business of determining what high value is for drugs or what any value is for drugs. I think that this is why they're looking for outside groups such as ICER to make this determination or definition for them, because I think CMS traditionally has not been allowed to make coverage decisions based on cost or value, for example. So yeah, really interesting question, but I don't know that definition exists.
Okay, all right. And speaking of ICER, so how did ICER kind of get the inside track to be the reliable or independent source for this?
So that's kind of an interesting one, and I'm sure that there are political and policy reasons behind that. I would just say that I think ICER has been able to raise its profile because they got a very big grant last year of about $5.5 million, and they were able to go from a pretty small staff to about 25 people. They definitely have been putting a lot of things out there with a lot of PR and news and media presence, and I think that they're also tied into groups such as AHIB, which is the industry group for health insurers, and they have some funding that comes from, I mean, they have funding from many sources, but they have a good amount of funding from groups related to payers, and I think that the payers see this as an opportunity to tighten up coverage and reimbursement, and so ICER is kind of on their side in that way, and payers are going to be advocating for or pushing ICER as that quote-unquote independent source. So I think that those are some of the factors in play. I also think it's interesting that Steve Pearson, who is the lead for that organization, had some experience in health policy in the U.S., but also was a fellow at NICE over in the UK, and kind of saw how that whole system worked. So something interesting to pay attention to. And yeah, I do think that this is a group that has kind of made a big splash on the scene relatively quickly, and is a high priority one to watch.
Okay. All right. And see, I think we have time for maybe just one more here. What is the best way to communicate to policymakers regarding the impact that this would have on patients and practices?
So there's about another week left, I think, at this point. So May 7th and May 9th, and I would have to check. I think one of those dates is public comments on the latest ICER report, which actually looked at multiple myeloma, and one of those dates is the deadline for CMS public comment. But I think that public comment is always one good way to go. Otherwise, most of the people on this call, no matter what stakeholder group you come from, whether that might be patients or providers or biopharma companies, you have associations and industry groups such as ACCC and others who are advocating on your behalf. So I think communicating what your concerns are directly through public comment opportunities and communicating your concerns through the groups in Washington that represent you are both important things to do in this case if you have an opinion on this.
Great. Yeah, and I will add from the ACCC perspective, we really are doing a lot of this in our advocacy realm. So, please visit ACCC-cancer.org, and we have an advocacy section on our website, and we lay it all out there as well, and really hope that the public does comment and does take the time to invest interest in this. So thank you as well.
Well, and Lauren, I will just add one. I have one note here that actually I got a little educated on this 1680 since that question. So in the note is that the 1680 comes from CMS's attempt to make that phase 1 budget neutral. So if you were in, for example, primary care, you might have been getting a good bit less than that, so that will bump you up, but then kind of shifts that away from the higher cost drugs and the higher cost specialties. So that's interesting that it didn't just come out of thin air, which is good to know.
Great. All right. Well, again, thank you so much, Jennifer Hinkle, for this really engaging presentation, and wanted to thank everyone in our audience for participating as well. The webinar and slides will be available on our website. Again, that's accc-iclio.org. So that's accc-iclio.org. And all registrants will receive an email with the link, so you'll receive that in your email box. And don't forget to save the date for our ICLIO conference. It's coming up on September 30th, and it'll be in Philadelphia. So please mark your calendars. We look forward to seeing you there. So thank you all, and have a good rest of the week.